Diamante needed to see a dentist because he had a toothache. It turned out it was an abscess. It became infected, and that infection spread to Diamante's brain. By the time he was admitted to an emergency room and received $250,000 worth of surgeries, it was too late. He had succumbed to that infection. He died at age 12 for want of a dentist who could have performed an $80 tooth extraction and saved his life. I tell you Diamante's story because the government is much better at issuing guarantees of access to care than it is on delivering on those guarantees. And not just access to care, anything else. I mean, think about it, if you like your health plan, you can keep it.
I just want to ask a question, because the question that begs then is, you think the government should then guarantee that there would be dentists who would take Medicaid?
Well, my answer to that is, why hasn't it? Because we've known about this access problem for years, and in states that have tried to expand access to, say, dentists and Medicaid, they've taken a number of steps. They've tried to eliminate administrative hurdles. They've tried to increase provider payments, and they will get the number of kids who are enrolled in Medicaid and receive dental care in a given year from 25% to maybe 33%, tops 40%. And it tops out there. After a while, you have to ask, is this a failed model? Are there other ways we could be making healthcare more accessible to the people we care about the most, to low-income people? I think there are, but we're never going to get them as long as this law is on the books. And so that's why I'm glad that the Supreme Court gave states more control over the future of this law.
Want to add anything here, Kathleen?
Well, the only thing I would say, there's no question that Diamante's death is a tragedy. I think without Medicaid, Diamante, unfortunately, would have also died with an abscess tooth that he couldn't get served, because I don't know any dentists who take uninsured people at all. About 85% of doctors take Medicaid. We have a real problem with dentists. I would say that as opposed to most healthcare providers in dealing with low-income people, there is a much lower participation rate. There's a much lower participation rate among dentists with Medicare patients also. And I think it is something that at least I feel strongly about, and we've tried to work with a lot of dental associations to look at what are the issues and what are the problems. But I think not doing something has a huge cost, and leaving millions of people without any health coverage has a huge cost.
Okay, well.
May I respond to that? I think that there are plenty of dentists who provide dental care to the uninsured. In fact, Missouri just passed a law that made it easier for out-of-state dentists to come into Missouri and give away free medical care and dental care to the poor, because under Missouri law,
or so there's
once a year, but under Missouri law, that was illegal. I believe that was illegal in, there's a similar law in Kansas. And this is an obstacle that state governments put in the way of low-income people accessing medical care. And it's not just out-of-state clinicians. There are prohibitions on dental hygienists practicing independently and providing low-cost dental care to people like Diamante and his family. Maybe that abscess could have been referred to one of those dentists who does see the uninsured, and we could have saved Diamante. I don't know, well, I think that there are dentists who will see the uninsured.
Well, I think that with this conversation we'll continue. We're going to add someone to the panel up here right now, and that's Daniel Landon, who is the Senior Vice President of Government Relations for the Missouri Hospital Association. And his current responsibilities include managing the association's federal and state legislative and regulatory advocacy functions, interactions with accreditation agencies, and the MHA Management Services Corporation's role in administering the hospital provider tax and associated Medicaid payments. I think get you plugged in there. First of all, please join me in welcoming Dan. So while we're miking you up there, Daniel, let me sort of just throw a question your way. Basically, so you're the Missouri Hospital Association. Basically, has the Affordable Care Act, the lack of expansion of Medicaid, what impact, if any, has it had on hospitals, particularly hospitals in rural areas?
It has had a significant impact. You'll recall that back in 2010, when the ACA was passed, it was clearly from someone who's been in and around legislative circles for a very long time, not a pretty picture. You might remember it was a really ugly way that it came law. But then, subsequently, a couple of years later, we had a Supreme Court decision that I'm unaware of anybody who really would have predicted would have happened. I mean, maybe there are people in the Beltway who thought that would happen, but it certainly took a lot of us out in Missouri by surprise. It's created a situation where the ACA has a component related to expansion that reduces significantly payments to hospitals under the Medicare program. Takes that away. As I think the ACA was intended, that money would be used to provide subsidies to expand coverage for people both in exchanges, which aren't an issue today, but also in Medicaid. And as state legislatures and governors were given the authority to decide whether or not that would happen in the individual states, such as in Kansas and Missouri, where it's not happening, it causes those payments to be lost to Missouri hospitals. They're not coming back to Missouri, and it creates a financially difficult situation because we still see the same number of people or more coming through our doors, sometimes emergency room doors, sometimes not, who are charity care patients. There's no one to pay their care. And the way of dealing with that in the U.S. healthcare system isn't particularly pretty. But it's created a financial pressure on the hospitals that I think has been significant. I would also note that our hospitals, which are bordering the 8 states that border Missouri, 4 of which have expanded. If you're in Memphis, Missouri, Scotland County Memorial Hospital, way up in the Iowa border, you could probably throw a rock into Iowa. Well, they talk to their counterparts, and they see that in Iowa, they do have a situation where the hospitals, as they say, have some more breathing room. No one is getting a windfall out of this. It was never designed to provide a windfall, but they have a level of lessened financial pressure that they don't just by virtue of the fact that you crossed that invisible line that defines Missouri from another state.
Okay, so the question is that, you know, so what happens? So you're losing your disproportional share percentage, and you're not getting expansion in Medicaid. What happens?
Well, by way of background, there's a payment stream for hospitals that's called disproportionate share, or DISH. In Missouri, it's entirely geared toward trying to partly offset the cost of the uninsured, not those on Medicaid, people who completely lack coverage. There is scheduled in the ACA, and it's been postponed, but there's scheduled significant reductions in the amount of DISH payments that can go to Missouri hospitals. The rationale for that is perfectly reasonable under the ACA. If you have more people with coverage, you don't need to pay so much money to the uninsured. But of course now the uninsured part is still there, the coverage part is not there, and the DISH cuts are coming, and especially in 18, they start out on our significant, which again exacerbates some of the financial pressures that our hospitals feel.
Well, I don't know if Missouri has had this situation, but in Kansas, a hospital just closed in Independence, Kansas. And at least the CEO of that hospital said there were a number of financial pressures, as there are in a lot of small towns, but he particularly identified the failure of the Kansas legislature to push forward the Medicaid expansion as one of the significant cost issues that they just couldn't make balance anymore. So hopefully you haven't had that experience yet in Missouri, but
we have actually in Missouri in recent year or two. We've had 2 hospitals close. Again, it's never entirely responsible.
Sure.
Medicaid is not the sole cause, but it is certainly an exacerbating factor.
And so just to clarify, what is happening here is that the ACA, Obamacare, created 2 new coverage expansions, one of the health insurance exchanges, the other the Medicaid expansion, and paid for it in part by cutting scheduled payments to hospitals and other healthcare providers. And when the Supreme Court said states didn't have to implement the Medicaid expansion, that meant states could cut off the subsidies that hospitals were going to receive to offset those cuts that they were that the Supreme Court left intact and the states can't touch. And so when states are complaining, or when hospitals are complaining about these cuts, they're really complaining about the ACA. They're complaining about Obamacare and not getting the subsidies that they were promised, which I think is a good thing. And if they have a problem with that situation, then they should address their concerns not to the state legislature, but to Congress, because it was Congress that put those cuts in the first place. But I think that I want to be a little bit controversial here and say that if we're focused on the impact that these policy changes have on hospitals, then our concerns are misplaced. What we should be looking at is, we should be looking at Medicaid as a jobs program that's supposed to keep hospitals in business and keep people employed there. The point of Medicaid is to provide health care to the poor, to improve the health of the poor. And that should be the metric by which we measure this program and all policy changes related to it. And the problem is that there is not evidence to show that Medicaid actually helps the people it's intended to help on balance. Of course, there's some evidence of benefit, but the most reliable research that has been done on this shows that it found no discernible effect of Medicaid on the physical health of the people, the most vulnerable people targeted by the ACA's Medicaid expansion.
I think you're probably referring to the Oregon study, I presume.
That's correct.
But nonetheless, let's get our fourth panelist up here, okay, and to join the conversation. And I would like for Tarren Bragdon to join us up on the stage. Tarren is the President and Chief Executive Officer of the Foundation for Government Accountability, which he founded in 2011. In just 4 years, the Foundation for Government Accountability has grown to one of the top 5 biggest state-based think tanks in the country. Prior to this, Tarren was the CEO of the Maine Heritage Policy Center, and from 1996 to 2000, he served in the Maine House of Representatives. Please join me in welcoming Tarren. Well, while they're getting this plugged in, and you've heard part as the discussion's been going, and I found it to be very interesting because at one level, my sense of what I'm hearing over here to some degree is that, that the perfect is the enemy of the good, or potentially is the enemy of the good. We're going to have a chance to talk about that in a second. That hospitals are the ones who are sort of affected. The Secretary has talked about how it was originally supposed to work together. So my question to you would be, what is your biggest objection to the expansion of Medicaid?
Sure. Well, I think, first of all, I appreciate the opportunity to talk with all of you. I think it's important to go back to 2010 and just look broadly first at what the promises of Obamacare were. One of the first key promises of Obamacare was that the average family would see a $2,500 reduction in their premium. The next big promise, the Congressional Budget Office said by last year, the number of uninsured would be reduced by 18 million. And the last big promise, as Michael referenced, was that if you like your plan, if you like your doctor, you could keep them. Well, the reality with the law is that those promises have either been completely broken or missed by a long shot. And what the law instead tried to do was to take a healthcare program that was targeted to the truly needy and expand it to a group of individuals who never received any type of welfare benefit at all. And it paid for that by enacting $716 billion worth of Medicare cuts. So just understand this for a minute. What the law did was it broke the Medicare promise to the disabled and the elderly, your grandmother, to give a Medicaid card to the 28-year-old living in grandma's basement.
Okay, well, I need to ask a question about that because there are two parts of this, and one goes to the tenor of conversations. Do you really believe that these promises or these aspirations were expressed knowing they couldn't be met, or do you think that basically what happened was the complications of the issue and having to sort of, what they liken, when Congress used to pass laws, when they were talking, it was like watching people make sausage. No one really wants to watch it. It wasn't very nice or pretty. But do you really think this was sort of a conscious notion that these promised, that what they thought would happen wouldn't happen?
No, I think that people were well-intentioned, but the problem in Washington is you can promise whatever, but when you pass a brand new entitlement, it doesn't matter whether you live up to the promise or not. It's the taxpayer left holding the bag. The challenge is, in Washington, they print money. It just comes out of a building. But in the state capitals, they have to balance their budgets, and they have to make trade-offs. And they have to live with the results of well-intentioned but poorly designed laws.